שלום לכל מי שנמצא פה, ערב טוב, תודה שהצטרפתם אלינו. אני שמחה לארח פה את ליה ג'ונסון, היא דירקטור של כל התחום המקצועי של עדשות הספיישלטי בקופר ויז'ן. תודה לכל מי שהצטרף אלינו. אני עושה פשוט, אני מאשרת תוך כדי, אז אני ככה לא מדברת ברצף, אז אני מתנצלת. אז בעצם אנחנו נפגשים פה הערב כדי לדבר על עוד פתרון לניהול מיופיה. אנחנו באמת רואים שיש לנו המון התפתחויות בכל העולם הזה של ניהול מיופיה. בוודאי רובכם שמעתם על כל הנושא של משקפיים לניהול מיופיה שאנחנו הולכים להשיק, וזה מאוד משמח אותנו, ואנחנו רוצים באמת לתת לכם את כל הכלים ואת כל הידע בכל הפתרונות שאנחנו מציעים בחברת קופר ויז'ן לנהל את המיופיה עבור המטופלים שלכם. ובעצם אנחנו מדברים פה על מגוון פתרונות שכולם בעצם נבדקו ונחקרו והוכחו כיעילים לניהול מיופיה, ולכל הפתרונות שאנחנו מדברים עליהם יש בעצם את התקנים שנותנים לכם בעצם את הביטחון לעבוד עם המוצרים האלה ולנהל מיופיה עם כל הרקע הקליני, ואני שמחה שאתם פה. זה כיף לראות את ההיקף של ההיענות ואת העניין שלכם בנושא, ואני מאחלת לכם שיהיה לכם ערב מענה, ושתעשירו עוד את הידע יחד עם ליה. So Leah, it's very nice to have you with us tonight. It's very honored for us, for all of our customers. Leah, as I said, she is the Director of Professional Affairs at Cooper Vision Specialty Eye Care. So, Leah, you can go on. Thank you.
Okay. Hi, everyone. And sorry, I don't speak any Hebrew, so this presentation will be given in English. But I'm really excited to share with you all today on myopia management with PARAGON CRT. And just a quick, I guess, poll, if you could, in the chat, how many of you are familiar with fitting Ortho-k lenses or PARAGON CRT? I'd be curious, to receive some feedback here. Anyone have any experience, or even if in the chat, if you want to say that you're brand new, you've never fit any Ortho-k lenses, we have one person saying yes, they are familiar. Okay, so we have some people who are a bit familiar with fitting CRT. So today I'm going to review with you myopia management with PARAGON CRT and how we can utilize this lens for myopia management. And so just to give a start, for those who may not be as familiar with Ortho-k, it has a very interesting history, because in the 1960s through 1980s, almost half a century ago, over half a century ago, these lenses were fit as flat-fitting, rigid lenses. They were just gas-permeable lenses, and so the fit was variable and unpredictable. And so people really just stopped fitting them because a lot of different studies from UC Berkeley, from other universities said that it was hard to get a specific fit for these lenses. And then starting in the 2000s, we really started to develop this new technology, reverse geometry contact lenses, to have this planned temporary reduction in myopia. The materials were made with higher oxygen permeability, and with corneal topographers, we can see here in this image, we really could get an idea of what these lenses would look like once they were in the eye overnight. And so when we look at, how does PARAGON CRT work? And this is one of our marketing videos that we have for our patients. Non-surgical, completely reversible treatment option. We have a lot of, with Cooper Vision, we have a lot of different options for myopia management. We have now spectacles that help slow down the progression of myopia. We have MySight, and with Ortho-k, it's kind of like, do you want an option to wear contact lenses during the day, or do you want an option to wear contact lenses at night? And at nighttime, the contact lens Ortho-k CRT reshapes that cornea so that when the lens is removed, the patient can see clearly. So let's look a bit about our US FDA regulatory history, because we have a lot of questions, what is myopia management? What is, myopia control? In the US, these lenses, Ortho-k lenses, were first approved for daytime wearing, just no overnight, just for the daytime in 1998. And then in 2002, Paragon Vision Sciences received approval for overnight wear. And so this approval includes Paragon CRT, Paragon CRT 100, dual axis. It also includes a variety of other lenses that you may see, RG4, IC, Fargo lenses. These are all under the same approval. It's with the HDS 100. The approval is up to 6 diopters, 1 point of myopia, 1.75 diopters of astigmatism for overnight wear. And this is in the US. And then a little bit later in 2004 with Ortho-k, Bausch & Lomb received approval. This is up to 5 diopters of myopia, 1.5 diopters of astigmatism. And you can see that there are many approved private label trade names in the US. In 2004, Euclid Systems also received its approval for overnight wear. And then in 2019, Minicon, actually in the US, also received its approval for Ortho-k wear. Now, it's interesting to note, in the US, every single lens is approved for the temporary correction of myopia. There is nothing in any of these lenses that really say that they help slow down the progression. When we look at, though, what does the contact lens and Ortho-k market look like? Well, for Efron in a paper, he says that this was a paper done in 2021, and it looked about at all, what are children being fit in? And Ortho-k represented almost 30% of RGP fits to minors, with half of those fits, right, from 6 to 12-year-olds. So we know that these lenses, while they're for the temporary reduction of myopia, are being fit in a large amount of younger children. And then when we look at a study by Wolfson, it says that Ortho-k was perceived to be the most effective method of myopia control. And this is an international study. So they polled over 50 countries and asked practitioners, what lens or what modality do you prescribe for children? Ortho-k was the most frequently prescribed myopia correction option for doctors trying to treat progressive myopia. And then in Hong Kong, there was a study that asked parents, why do you choose Ortho-k for your child? Why did you choose this modality? And Hong Kong parents perceived Ortho-k as the most effective method for myopia control for their children. And then when we look really globally, though, and say, how many people are being fit in Ortho-k? It's a very small percentage, right? So Ortho-k fits are about 1.2% of all contact lens fittings, and that's globally, but it has increased, right? So in 2004, it was about 0.5%, and it's almost, tripled from in 2017. But when we look at such a small number of all these fits, we see that actually they're being fit in all these children. So this just brings us an interesting point that while all these lenses in the US are approved for the temporary correction of myopia, that many of these lenses are being fit in children. So let's look at some of these ocular changes happening with Ortho-k. And we can see from topography, immediate changes, right? On that first night of overwear, we see these changes. And we also can measure on biometry that, we have these axial length changes. And so this is an instrument that measures a patient's axial length over the course of many months. It looks at their change in refractive error along with the change in their axial length. And so we can see that from studies that we are going to review, that patients who do wear Ortho-k lenses do have less axial length elongation overall than children who are wearing single vision lenses. Another great reason to prescribe Ortho-k lenses is really to enhance a child's quality of life. In different studies that have looked at quality of life with children wearing Ortho-k, they mention things such as independence, and they say, it's awesome that I can see lenses, I can have clear vision 24/7. They also mention that they have new confidence in their behavior because they can see clearly without their glasses. They're much more likely to do other things. They can try new things. They have improved self-image. So children wearing these contact lenses, Ortho-k overnight, say that they can go outside without worrying about breaking their glasses. So they're spending more time outdoors, which we know is good, especially as a protective effect against myopia progression. In terms of social relationships, because they're more likely to go outdoors, they have improved self-image, they're more likely to try new sports and activities in school. And then lastly, but this did not improve, the students felt that they had better academic achievements. They said they felt more confident in their school grades, although we do know that they did not actually perform better just by wearing Ortho-k lenses. All right, so let's look at some of these studies, right? So we say that we have the first Ortho-k study by Dr. Pauline Cho in 2005. And this looks at the efficacy of Ortho-k on axial length changes. And we can see that over 2 years, the children wearing the Ortho-k lenses progressed about 50% less than the children in spectacle lenses. And so this was really one of the first studies that said, we may have something here in that these children wearing Ortho-k lenses, their axial length is not progressing or increasing as much as children wearing spectacle lenses. And so as we continue to look at these different studies, we have Jeff Walleen in 2009, who compared Ortho-k lenses to soft contact lens single vision. And we can also see that over the course of 2 years, these patients progressed about 50% less than the patients wearing single vision lenses in terms of measuring their axial length. And then, right, we're always worried about the safety of these children wearing, we have pediatric patients wearing contact lenses overnight. And so in some of these different studies, one, we look at the Clay study, and this looked at patients with soft contact lenses, but it was also children wearing contact lenses. And they said, why are children having adverse events? What are the risk factors? And, are we more worried about an 8-year-old wearing a contact lens versus an 18-year-old? And what they found out from the Clay study is it's not the age, but it's the behavior at certain ages. So we can see here that at age 8 through 12, they actually have a very low incidence of adverse events for children in contact lenses. And what they, extrapolated from this is that these children are much more obedient to their parents. Their parents are a lot more hands-on in ensuring the care and compliance of lenses. And then as the children reach their teenage years, they tend to not listen to their parents as much in terms of compliance. And so the adverse events per 10,000 patient years starts to increase. And then when these children go off to college and aren't under their parents' supervision, that's really when the contact lens adverse events increase, and they decline after the patient is in their mid-20s to early 30s, and they tend to be more compliant. But what we can take away from this is that these children, 8 to 12, right, these children who are just now wearing their lenses for the first time, they're actually in the safest group because they are much more compliant. They adhere to safety and to making sure that they have good safety and hygiene for their lenses. And when we look at the safety, and in a retrospective study of safety of Ortho-k, and this looked at over 3,000 patients, we have 1,300 patients who were, half 50% adults, 50% children, and we have another study that looked here at 2,500 patient years of wear, right? How long have they worn the lenses? And overall, the study with Dr. Mark Bullimore says that there's about 7.7 cases of MK per 10,000 patient years. And so what does this mean? Well, for us, we had 0 cases of microbial keratitis in adults and 2 cases of microbial keratitis in children with no loss of visual acuity. So between these two, for children, the safety level is about 14.4 cases of microbial keratitis per 10,000 patient years. And then we divide that because there were no cases in adults, and that's where we get the 7.7 cases. So overall, the incidence level of microbial keratitis is much lower than a overnight silicone hydrogel lens that a patient is also approved to sleep in for extended wear. So we know that the safety and the risk of Ortho-k is not higher than these other modalities. Okay, so let's look at myopia management versus myopia control. In the EU, there actually are Ortho-k lenses approved for myopia control. And so it brings us to the question, what is myopia management? And I'd be curious to hear from any of you in the chat box if you want to give your thought on myopia management. But we actually asked the US FDA and we said, what does myopia management mean? And how does it differ from myopia control? And what myopia management, it's a very loose term to infer for the correction and managing of myopia, of the refractive error. And that is what the FDA considers as myopia management. Myopia control. The US FDA thinks of myopia control as an actual approval for indication that slows down the progression of myopia. And so in the EU, we have the CE mark approval, and this is for myopia control. And so in 2019, Minicom Bloom was the first lens to receive myopia control approval in the EU, followed in 2020 with PARAGON CRT, and then in 2021 with ProCornea Dreamlight. And so in the EU, these 3 lenses now have that approval that say, yes, we have looked at the studies in the past 20 years, and we can say that these lenses do slow down the progression of myopia in the EU. So that is what, that is the difference. Now, are these 2 interchangeable? I would say that in clinical practice, for the means and purpose of, talking to patients, we may use these terms interchangeable, but according to the US FDA and to regulatory bodies, they are not interchangeable. One is an indication for the slowing down the progression, and the other is a general term to show that we are managing the refractive error condition of myopia. All right, so the US FDA says that they are not the same and that there are no current lenses in the US approved for myopia control for Ortho-k. However, MiSight is approved for myopia control in the US. And in Europe, we have the CE mark approval for these Ortho-k lenses, for the MiSight spectacles, for MiSight daytime contact lenses as well. All right, so what are considerations in choosing an Ortho-k design? You have a patient, right? We say we're going to perform, we want to start this child in a modality to slow down their myopia progression. And so we want to take into consideration some patient data. What is their corneal shape? What is their level of myopia? What is that target treatment that we're going to receive? If we have higher amounts of myopia with a flatter K value, we know that that's going to be a much harder or complicated patient versus a patient that may have average Ks and lower amounts of myopia. And then after you have these patient considerations, the next thing you want to look at are what are your practice considerations? Do you have a diagnostic dispensing set where you can place a lens on the patient's eye and see, get an idea of how does that trial lens work? Do you want to empirically order the lens? Do you want to go with a software-based approach? We have instrument-driven fitting Ortho-k lens designs. We have doctor-driven fitting, where the doctor makes all the changes themselves, or we have consultant-driven fitting, where the consultant is the one making these changes. So there's a lot to consider when integrating Ortho-k in your practice. But when we get to PARAGON CRT, PARAGON CRT has the highest FDA approval of any Ortho-k lens, and this is across the world to correct the amount of myopia. It's approved up to 6 diopters of myopia and 1.75 diopters of corneal astigmatism. This approval is for patients of all ages. However, in Europe, the approval has been set for starting of 6 years of age, and that's according to the new MDR. And so when we look at this PARAGON CRT lens, and I saw from the chat box that some of you have, are familiar with fitting this lens. So just to review, it has 3 parameters, right? We have the base curve, which is the treatment zone, and that's going to be the curvature that eliminates or reduces the amount of myopia in a patient. We have the return zone depth out here. This is this dark purple band in the diagram, and you can see it has this fluorescein underneath it. So that's the return zone depth. And then we have the landing zone angle, and this helps control the edge lift of the lens. And so what I love, the beauty about CRT lenses is that you only have 3 parameters that you really can choose to change to get the optimal fit for a patient. And all these parameters are laser marked inside of the return zone depth. And so you can actually verify that your patient is wearing the correct parameters. The first 2 parameters account for the base curve. The second 2 parameters account for the return zone depth. And if you see something like a 58, that's actually a 575 that's rounded up. And then the last 2 parameters account for that landing zone angle. So let's just talk a little bit about these parameters so that you can understand how to get the optimal fit for your patient wearing CRT. And so as I mentioned, this base curve provides the mold for the Ortho-k treatment for myopia correction. Here's the treatment curve. And as we change this treatment curve, we can either make it flatter or steeper to match that patient's corneal K values. The base curve is adjusted only when the refraction over the lens is not at its target value. And so our target value for the base curve, we want to check with the lenses on the patient's eye, and we want to say, what is that refraction over the lens? And we're looking for about a +50 to a +1. Now, why are we looking for a little more plus? It's because the back of the lens does not conform exactly equal 1-to-1 to the front surface of the cornea. It's not an exact 1-to-1 corneal stamp. We know this because if the patient were to return in 6 months and we would see an alignment pattern, but we always see, we see that central bearing, or not landing, but we see the central bullseye, landing with the mid-peripheral pooling. And so because of this, we always want to target that base curve just half a diopter to a full diopter, flatter than that flat K. All right, so when do we make base curve changes? So let's give an example. Let's say that the patient is about 20/25, and that refraction over the lens is a -50, right? So we need -0.5 to get them to see clearly 20/20. Let's say the original base curve was an 8.6. So with that ROL as a -50, and we want to get to a +50 as our target ROL, that means we're going to flatten. We need to go a full +1 diopter. So we need to flatten that base curve to an 8.8, right? So we need to flatten that base curve 0.2 millimeters to change that 1 diopter change. So we would flatten the base curve by an additional 0.2 to have that correct target correction power for the base curve. All right, so our second parameter that we have is the return zone depth. And the return zone depth controls centration of the PARAGON CRT lens. It controls really that overall sagittal depth. And we want to match the depth of the lens to the steepness of the cornea. And so it's measured in microns of sagittal depth, and it's adjusted in 25 micron increments. And so because not all corneas are spherical, and we want to really adjust the sagittal depth of that return zone depth to align with the cornea, we have dual depth RZDs available for a toric cornea as well. And so we call these for dual axis. You can see here, this dark purple in the mid periphery is the return zone depth. And as we play this video, we change in 25 micron increments. And so this will match the sagittal depth of the cornea to get the best centration. And so deeper RZDs are 600, and these are going to be more for patients with a steeper K value. And for patients with a much flatter K value, the RZD is going to be in a 525, 500 or so. And so you can see here from an example that we have this patient in a 550 RZD, and this is exactly what we need, right? We have the right proper sagittal depth of the lens to fit the cornea. However, if we go 50 microns flatter, we now see that we don't have the proper sagittal depth. That lens is too flat and is going to decenter superiorly. And then if we go on the opposite way, 50 microns deeper, now we see that we really have this cornea with a very faint bullseye pattern, too much fluorescein. We kind of have this bubble out in the mid periphery, right? So this lens has too much sagittal depth for this cornea. And so our perfect fit here is this 550 RZD for this cornea. Let's see, do I have any questions? I have one. Will the refraction over the lens depend not only on the base curve, but also on the back vertex power? I would say no, because of the way Ortho-k works, we have that tear film, and that tear film is actually, the base curve is eliminating with the tear film. That patient should be plano through their lens, but we actually push a little more plus to allow for any regression throughout the day. All right, so the third parameter that we have is the landing zone angle, and this controls the amount of edge lift. And so you can see here in this blue, we have 34 microns. And so this is measured in angles of degree. And CRT is really unique in that the landing zone angle is actually a straight tangent line. It doesn't have a peripheral curve as other, gas permeable lenses. There's no peripheral curve. It's a tangent landing zone angle. And so when we change this, a 34, a 33, we're having a flatter angle, a 32, or a 31, that's even flatter, right? And so each 1 degree change changes the sagittal depth by 15 microns. So think about it. If you make the angle 1 degree steeper, that's going to increase the sagittal depth of the lens by 15 microns. And that's going to give an overall different fit for the lens, for the patient's fit. If we lower the landing zone angle, or we make it flat, if we flatten that, right, from a 34 to a 33, we're now flattening that edge lift, and that edge lift, now the lens is going to sit 15 microns closer to the cornea. And so we can also have dual landing zone angles for toric peripheral corneas, and we'll talk about that in a bit with our dual axis lens. So the lower the amount of degrees, the flatter the edge. I tend to think of like the 0 as a horizontal plane. And as we increase the numbers, we have increased steepness. And so a 34 is a steeper edge or tangent angle compared to a 31. And so here's some examples of, when to change the landing zone angle. So we're typically looking for about 0.5 millimeter to 1 millimeter of fluorescein. So the lens is actually landing out here in the mid-periphery. And then this is the amount of angle of that edge lift from where the lens is landing on the cornea. And so for 32, we have too much edge lift, and this patient is going to experience lens awareness. The lens can actually move excessively, and so it won't be very comfortable for the patient, and we may also not get proper centration if the lens moves off the cornea, especially when we consider that lid-lens interaction. As that lid blinks and pulls up the lens, if it is too loose, that lens is going to move excessively. So we're looking about 0.5 millimeter to 1 millimeter of edge lift here. And if we see here, now we increase that edge lift to a 34, and now there's barely any fluorescein underneath that edge of the lens. And so that's minimal, and we don't want that. Some, I guess, subjective symptoms that you can see for a patient when they have too tight of an edge lift is that they'll have fluctuation in vision. You may get slow treatment because we do want proper tear exchange underneath this edge lift of the eye. And you actually may even see corneal damage, right? We may see superior punctate keratitis, we may see corneal staining, and so we don't want to affect the ocular health of the eye. So therefore, we want to have a slightly flatter edge lift to give that proper tear exchange. So who are ideal PARAGON CRT dual axis candidates? We've talked in the, and we have 3 parameters, our base curve, our RZD, and our LZA. And we say that we can make our RZD and our LZA in 2 different parameters, and this would be for a dual axis patient. And so we recommend dual axis, or having 2 RZDs and 2 LZAs for patients with corneal toricity greater than 3/4 of a diopter, for patients who have incomplete treatment with their CRT spherical lenses, and then also for patients who have this incomplete peripheral alignment in one meridian. If we see at the 6 o'clock mark, this patient has a toric cornea and they're wearing a spherical lens. And so as that lens drops, we can see that we're not having that nice 360-degree alignment in that mid-peripheral area. And because of that toricity, now we're seeing the fluorescein as it's bleeding or leaking out through the edge. And so when we look at the PARAGON CRT dual axis design, it's very similar to the CRT lens design, except that now we have 2 RZDs and we have 2 LZAs. And so these are going to be in 90-degree meridians apart from each other. All the meantime, that base curve optic zone is still going to be spherical. So you can have a lot of different options with CRT dual axis. If we have a patient with apical astigmatism, we may just want to choose 2 RZDs, so an RZD1 and an RZD2, and we have a 1 LZA for that landing zone angle because this patient has more apical astigmatism and that periphery is spherical. We may all have patients also who, as we have larger lenses, we may want to have that toric peripheral edge lift. We know that the horizontal cornea peripheral is much flatter than the vertical peripheral cornea. And so for this patient who's spherical lens, but they're wearing a larger diameter lens, we may want to keep the RZD the same at 500 spherical, but change those landing zone angles to more closely match that toricity of the cornea. And then we can also have, for patients with limbus to limbus astigmatism, dual RZD and dual landing zone angles. So we can see here that we now have a 500 in the vertical meridian, 550 in the 500 in the horizontal meridian, 550 in the vertical meridian, with a 33 in the horizontal meridian, 34 in the vertical. So the first RZD1 and LZA1 are always going to be the shallower parameters. So the 500 is going to be the RZD1. That's and then the 550, the steeper, is going to be the RZD2. Okay. So when we look at the PARAGON CRT dual axis laser markings, they are also marked 90 degrees apart because the treatment zone or the base curve is the same. We don't repeat that, so it's an 8-0. Now we can see here the next two digits, the 55 stands for 550, 58 stands for 575. So we know this is a dual axis return zone depth. And then we have a 33 landing zone angle and a 34 landing zone angle. And so this is what the lenses look like on the patient. Because the lenses are laser marked inside of the RZD, when you put the lens on eye, the numbers will be backwards. So here we can see this is a 7.9, a 5.25. We can read this as a 53. So that's a 5.25 and a 33 as the landing zone angle. And here are the parameter markings for the dual axis lens. And we can see here that the patient is an 8.4 base curve, a 5.50, 5.75, 34, 35. All right, so the last parameter that we really want to make sure that we have correct is the diameter of the lens. And diameter is so important for centration for a PARAGON CRT lens. In general, CRT lenses tend to, if fit improperly, tend to decenter superiorly more. And so we want to ensure that we have the proper diameter size to make sure that we have correct centration. Diameter is measured in 0.5 millimeter steps. It's adjusted based on the patient's visible iris diameter. And so we recommend visible iris diameter -1 millimeter for the full lens diameter. So when we look here, we can see on topography that we have, this patient is measured at 11.38. Because the horizontal visible iris diameter is cut off, we're actually using an oblique diameter. But if we subtract 1 millimeter, we see that we're reaching about a 10.38. And so the recommended diameter is going to be a 10.50. When we look for for a larger diameter here, we can see that this patient is a 12.06 -1 millimeter, you get an 11.06 millimeter. And so this recommended diameter would be an 11.0. All right, so once we have an Ortho-k lens, CRT, and we're going to, fit that patient, what are our protocols into bringing that patient back for patient care? Well, we have our lens dispense, and then we want to look at the 1 day, the 1 week follow-up, a 1 month follow-up, and a 3 month follow-up to ensure that we have the proper follow-ups and that the patient is, keeping to compliance, they have continued care, and we can make sure that we have overall the patient success. So what do we do for this patient when we have examination with lenses on eye? Well, while the patient is wearing their lenses, 1, we want to check their visual acuity. I have the patients, when they come back for their 1 day follow-up, I like to have the patients wear the lenses on. So to not remove the lenses, after we dispense the lenses, we have them for the 1 day, and I tell them, come in wearing your lenses, we're going to check your visual acuity, we're going to check that refraction over the lens, we're going to check slit lamp examination. I want to see with that lens on, is their lens binding? How tight is that lens on the cornea, or does that lens, move freely? And so we want to look at the centration, the edge lift, and the floor seam pattern, and then we can reinforce that proper application and removal technique. And so here we have a video of an optimal PARAGON CRT lens. We're looking for that centration, about 3 to 4 millimeter base curve or treatment zone, that nice uniform landing out in the mid periphery, and appropriate edge lift of about 0.5 to 1 millimeter. And then we'll have the patients remove their lenses. We can check their visual acuity, see, what is their 1-day visual acuity follow-up. We can perform an auto refraction and a subjective refraction to see, if we need to, for children who are younger and lower myopes, typically they should be about 50 to 75% corrected within that first day. And they can just wear an old pair of glasses to get them through that day and for the next day. But treatment should occur in about a full week. They should have great treatment. And so we just tell the patients, just wear an old pair of glasses. You can assess corneal health, and if available, check topography as well. All right, so what do we want to look at, in utilizing topography? In that first day, we see that, we want to look at this treatment zone. And a lot of times it's not going to look this well defined. And so, there's different ways you can change the parameters on the topography so that you can actually change the settings to make the picture look a lot more desirable, like you can see from these topographies. Then we have the 1 week outcomes, and we can see that we have a lot more central flattening with that mid-peripheral steepening. And so the treatment is that flat and blue center here. And we want to make sure that it's pretty much surrounded, it's over the pupil, and it's surrounded by a full mid-peripheral ring. And so here's some examples of, what I was saying here is this is kind of like a really nice example of that 1-day topography, but you're not going to see that in a lot of your patients. Here's what you're actually going to see, right? So you can see here that we don't really have that fully formed ring, but it's 1 day. I say as long as it's decently centered, there's no harm to the corneal, health, and that we have a lens that isn't binding to the cornea, that at 1 day we say that looks great, So when do we want to change a Paragon CRT lens? At the 1-day follow-up, as I said, if we're having any moderate to severe corneal epithelial defects, we know that that lens is rubbing on the cornea, and we want to make sure that we change those parameters. If we have insufficient edge lift where that lens is binding to the cornea or it's stuck on the cornea, then we know that we're not having enough clearance and tear film exchange. And so that patient is not going to do well at their 1 week. So we also want to change those lens parameters. And then if the refraction over the lens is not at target, let's say it's for some reason a minus or a -1 or something, then no matter how well of a fit we have, if that base curve is not calculated to flatten that central cornea, we're not going to get the best fit. So we also need to change that ROL. And so then when do we change at 1 week? I say for mostly 1 day is a health check, and we want to make sure that the patient has, good health, corneal health, and then we bring them back for their 1 week follow-up. So if they're having more than 0.5 millimeter of decentration on topography at 1 week follow-up, we'll want to make some changes because a lens that tends to be decentered will continue to be decentered unless we change those parameters. If we're seeing uneven treatment on post-treatment topography or under correction, that's when we want to start considering, what lens parameters should we change. So who are our ideal Ortho-k candidates? Myopic children, right? They have flexible visual requirements. They're not driving at night, so they don't have those critical vision needs. Patients who have a strong motivation to be spectacle free, patients who lack the independence of soft contact lens handling. We're also looking for patients with good hygiene and maturity. And if you're getting started, really you're low to moderate myopes with an average corneal shape, you want your Ks in 42 to 45 and less than a diopter of toricity. And this is when you're really first selecting your initial Ortho-k candidates, because then you're going to build confidence as a practitioner to fit Ortho-k lenses. So let's take a patient clinical example here. We have a 7-year-old female. She is, school age myopia, 7 years old. She's already myopic. She likes to swim. She's in gymnastics. She doesn't spend much outdoor time. She has a moderate amount of time near work, and her parents are very hands-on. So for a lot of reasons, this is a patient candidate that I'm thinking they would be a great Ortho-k candidate. Patients who are swimming or around water, and so we don't want patients, wearing contact lenses in the water. And gymnastics, actually, they use a lot of dust and chalk. And so I've had patients where that chalk and dust gets stuck on their soft contact lenses and is irritating. So if we can give her an option where she doesn't need to wear her lenses while she's in these sports and activities, that would be Ortho-k. Her parents are very hands-on. Ortho-k is unique in that the parents can, watch and supervise the child putting on the lenses, or, it's the lens wear time is always at nighttime and the supervision at home. And so for this patient, we said, we're going to go with Ortho-k and CRT. So we take a look at her refraction. She's 7 years old, a -1, -125. We look at her K values. Her flat K is 4382. She's got mild corneal toricity, but not that much. Almost half diopter in the right eye, less than a quarter of diopter in the left eye. And her corneal diameter size, when we measure it here through topographer, is about 11.72, 11.67. So just looking at these parameters and knowing that she's under 3/4 a diopter of toricity and her K values, I know that we're going to go with a spherical lens. And if we roughly subtract 1 millimeter from her HVID or corneal diameter, we see we're going to get about a 10.5, right? 11.7 minus 1 is a 10.7. So she's going to be in a 10.5 millimeter lens. All right. So this is where you get to take out your phone, if you have one nearby, and you can scan one of these QR codes. So this is how we calculate our lenses now with PARAGON CRT. It's going to tell you what lens parameters you need for your patient. We have a website that's here called crtcalculator.com. However, if you have an Apple, an iPhone, an iPad, you can actually scan this QR code in the upper right-hand corner, and this will take you to our CRT app. And if you have an Android, a Samsung, any other phone that uses an Android platform, you can scan this QR code in the lower right-hand corner, and that will take you to the Android store app. Okay, and so let's see here. So this is what the online version brings, the website. And so you can see here that we're going to place the patient's RX. She's a -1. We're going to place her K values here as well. She's a 43 and a 44. We're going to put her visible iris diameter. We can choose our optic zone, 6 millimeters or 5 millimeters, and we can choose the Jessen factor, +50 or +1. And so this results here gives you, what parameters you would need to either trial on the patient, or you can order these lenses for the patient. We see that she's in a PARAGON CRT spherical lens, and so we're going to order her an 80, 525, 33. I like to customize the right eye in red, right red, and the left eye blue for left. So for this patient, we have our 1-day visit. And we can see here that her refraction over the lens was our targeted +50. Her manifest refraction, she was about a plano and a -1/4 sphere. But that's just the 1-day follow-up. And so when I look at this topography, I say, this looks pretty centered. We looked at her, evaluated her corneal health. There was no staining. So we say, even though we're not getting that perfect, bullseye pattern, dramatic red ring steepening, it looks pretty great. So we're not making any changes at the 1-day follow-up. And then when you have the 1-week follow-up, we see here that we have a much more dramatic central flattening and paracentral steepening. All right, so let's do one more case here. This one's, we have a 12-year-old male. He's worn glasses for 7 years, which means he's worn glasses since he was 5 years old, right? So we're like, okay, you had myopia at a very early age. And we know that from studies that children who have myopia at earlier onset progress much faster. You know, he plays video games, he gets good grades in school, he has moderate near work, but he does play baseball outside. And so baseball is another sport that really has me thinking, you know, there's dust. And so I think he's going to benefit from wearing Ortho-k and CRT lenses because that dust is not going to stick on his soft contact lenses if he is outside and among wind and dust and so forth. Okay, so we look at this clinical data here. We see that his refraction is about a -5, -475 with a diopter and a half of a cylinder. We see that this kind of matches to his steep Ks and his flat Ks. We have a diopter and a half of corneal toricity. And we see that he has slightly larger corneal diameter. And so we see that we have about 12 millimeters -1, which means that we want to put him in 11 millimeter lens. So when we put this into the CRT calculator, we see that our initial lens selection here is now going to be a dual axis lens. So for this patient, we can see that he pretty much has, you know, a good amount of astigmatism for both of these corneas, and especially, so we're going to also want a dual landing zone angle and a larger diameter as well. So this is what our calculator tells us is the best initial lens selection for this patient. When we look at his 1 week subjective refraction, where's it going? We see that he's still undercorrected by -1 diopters, right, in his right eye and -1.25 in his left eye. And so when we look at that refraction over the lens now, we see that it's actually -50. So we could use a little more flattening of that base curve to help us achieve the correct base curve calculation. So remember, half a diopter is 0.1 millimeters. And because he's -50 and we want to get him to +50, we're going to want to flatten the base curve by 0.2. And so we'll go from an 8.7 to an 8.9 base curve. And so this is, you know, we can have so many different reasons and why we need to change lens parameters. So I'm happy to email this to Ortho and she can share it with all of you today. This is a PARAGON CRT troubleshooting card. You know what to do when you have lateral decentration, superior decentration. What do you do for a patient, you know, who's already wearing a CRT dual axis lens and we have superior decentration? You know, what parameters should we change? And so this can give you an idea of what parameters we need to change for that patient to have an optimal fit. So 3 quick tips to leave you with, you know, on how to achieve the best CRT lens fit. First of all, you want to maximize centration with a larger diameter lens. You know, keep that in mind. Keep their corneal diameter -1 millimeter. Larger diameter lenses center better. A centered lens is going to have a much better treatment. If a patient has corneal toricity over 3/4 of a diopter, utilize the CRT dual axis lens. If you use our lens calculator, crtcalculator.com, or you can use the Android or Apple app, it will automatically calculate that for you. And then you want to make sure, check the refraction over the lens. I know it sounds a little bit counterintuitive because we don't wear Ortho-k lenses during the day, but you want to make sure that that base curve is calculated flat enough for that patient's target correction. So you want that refraction over the lens to be a +50 to a +1, and you may need to flatten that base curve. And so with that, I'm going to say thank you. Does anyone have any questions? Let's see, I got one question. If you change any of the parameters at any stage, do you start the assessment if starting from new? Yes, I would say that if I'm changing the parameters, if the lens is centered and we're changing some parameters, then I keep the lens centered. But if the lens is decentered, let's say we have superior decentration and we see that on topography, then I'm going to have the patient wash out or stop wearing that lens for a little while. And I do want to start from new because that decentered lens tends to ride to where that corneal mold is set. And so now we're setting ourselves up for failure because even if we have the correct parameters, that cornea is already molded superiorly decentered. And so we won't be able to get better centration. So for those patients, I will have them stop wearing their lenses. If it's only been, if they've only been wearing it for a week or two, I just say, hey, don't wear your lenses tomorrow for the next 2 days, and we're going to put you in a brand new lens. Another question, what is the Jessen factor referred to in several slides? Yes, so Jessen factor is the compression factor. And it's really, George Jessen came up with this terminology that says, we actually, for Ortho-k to work, we need to flatten that central cornea about half a diopter to a diopter more than what the corneal amount of myopia is that's needed. And this is to account for regression throughout the day. It's also to account that the back of the corneal lens does not form that perfect one-to-one stamp on the cornea. And so we actually need to have a flatter base curve than what is calculated for how much we need to flatten that patient's central cornea. Another question, if fitting CRT for myopia control, do you fit a smaller optic or treatment zone than in standard cases? Yes, so this is an interesting question. We now have, and I didn't talk about it for the sake of time in this presentation, the 5mm optic zone. And a lot of doctors we see are using they are looking for a smaller treatment zone on the cornea. And so by fitting a smaller optic zone, we've seen from our clinical studies that we performed at UC Berkeley that we are getting that smaller treatment zone on the cornea. And there are theories that show that that is better for slowing down the progression of myopia. We don't have any long-term studies for this. This is all a theory and a hypothesis. Smaller treatment zone can also increase higher order aberrations, which we know that these spherical aberrations help with myopia control as well. But all of that is hypothetical theories. So right now, I can't say one way or another, other than we offer the treatment, and we do have doctors who are using the 5mm optic zone. You can calculate that using the CRT calculator. I'll just type it in here, crtcalculator.com, and you can convert that for your patients. Any other questions? Well, thank you everyone for sharing this time. I know it's late in Israel, but I appreciate your interaction and sharing this time with you to speak on PARAGON CRT and myopia management.